Okay, welcome back, everybody. We have two great speakers for this next lecture. Dr. Stephen Sorkin serves as the Director of Specialty Contact Lens Services at Corneal Associates of New Jersey in Fairfield, New Jersey. He earned his Doctor of Optometry degree from the State University of New York, where he is still adjunct clinical faculty. He lectures extensively throughout the United States and internationally on contact lenses, ocular therapeutics, and corneal diseases. Suzanne Sherman is an assistant professor of optometric sciences and ophthalmology and director of optometric services at Columbia University Irving Medical Center. She specializes in complex and medically necessary contact lens fittings, anterior segment disease, and primary care. She received her undergraduate degree from the University of Michigan with a degree in brain behavior and cognitive science. She also graduated from SUNY College of Optometry and completed her optometric residency in ocular disease and primary care at the Bronx Lebanon Hospital Center. And they're both fellows of the FSLS. So welcome and take it away.
Thank you so much to the Scleral Lens Education Society and to Wu University for having us. It's a really big honor to be here today. It's also an honor to be lecturing with Dr. Sherman again. Okay, so we're going to talk today about unique uses of scleral lenses. You guys have heard some really great talks earlier about glaucoma and keratoconus. We're going to touch on some more unique, special type of patient population that we have been helping with scleral contact lenses. And there are disclosures. All financial disclosures have been mitigated. Okay, so our primary uses for scleral lenses, as we all know, and in my practice, I'm sure you too as well, Suzanne, is really keratoconus and corneal ectasia. So I'd see probably 10 to 12 keratoconus patients every day. I see, from early diagnosis to following them through the transplants and beyond. So we do see a lot of patients with corneal ectasia and keratoconus, post-LASIK ectasia, and obviously a lot of post-surgical cases as well. Okay, so we do know the benefits of scleral lenses. I'm looking at, greater comfort and stability versus some other options. We know that the lenses do not rest on the cornea, and you do get typically improved vision because you have a larger optical zone with a bigger lens and better centration as well, which does help with vision and comfort also. And there's much better stability and security with the scleral lens versus other options. And we do always go through the personal questions of what a patient does for a living as far as their work environment. Let's say they're working in a warehouse and they have a dusty environment. Also what their sports and hobbies are. So these are all things that we take into account when we're prescribing contact lenses, determine if scleral lenses are the most appropriate way to go. So obviously we're in the business of rehabilitating vision. We're trying to help people see better. And that's where with the regular corneas, corneal scarring, corneal dystrophies, as you see here on the right, you have a patient with a lattice dystrophy, and also that post-surgical cornea, such as collagen cross-linking, intrastromal corneal rings like Intex, or Ferrara rings, post-RK patients, and post-surgical patients for refractive surgery, such as PRK and PTK. But when we get into more challenging types of corneas and eyes, we're dealing with things such as ocular surface disease. And these are things like Stevens-Johnson syndrome, which of course is a very challenging condition, mucocutaneous idiosyncratic condition that happens. I have dozens and hundreds of patients probably with Sjögren's disease, which can be very challenging to manage. Graft versus host disease as well is a challenging condition. As you see there on the right, there's a photo of a patient with neurotrophic keratitis. You have exposure keratopathy and also limbal stem cell deficiency. These are also, very challenging to fit and also to manage. So you're not only fitting the cornea, obviously, but you're also managing their concurrent ocular disease. And this is one of my patients that has limbal stem cell disease. You can see there, you see the whorl keratopathy that's there and the diffuse SPK. And these patients can be challenging to manage. Sometimes these patients require scleral lenses along with other topical treatments as well. And this is a patient with Stevens-Johnson, where you see the scarring and the neovascularization there. They get keratinization of the lids and blepharon. These are challenging conditions that you do see with those patients. So this goes out of the realm of a typical keratoconus patient that we're seeing all day long. Okay. Sorry about that. Let's go back one slide. All right. So just, going into, looking into doing this lecture, I wanted to kind of see what we as a profession are doing and our colleagues are doing to treat and prescribe scleral contact lenses. So this is the seminal study back from 2015. Riro Chernak and her team there, they did a great job in surveying a bunch of docs, and almost 800 doctors responded to this. Now, this is back again in 2015 when scleral lenses were just starting to become a thing. Before that, it was really just very few practices were doing it. Very few practitioners were prescribing scleral lenses. So this is really when things just started to really boom. We were getting things like the Scleral Lens Society was formed, and a lot more webinars, a lot more lectures and articles were coming out. And this is really where it just all started. So you can see on the left, that's keratoconus, and just about all the respondents basically were fitting patients with keratoconus with scleral lenses, pellucid, refractive surgery. And then as you go down toward the right, you see these are much more less prevalent as far as docs that were fitting these patients. You can see the dreaded presbyopia all the way on the right. That was very, very low prescribing. So this was the original scope study back in 2015. What was interesting when I looked through this study is that this is really showing the corneal diameter and really what the prevalence of prescribing contact lenses. Kristen had talked earlier. She was mentioning that she likes to fit larger lenses. Most of us, will fit 15 to 17, kind of being their default, and that's your regular, bread and butter. Most fits are going to be in that 15 to 7 millimeter range. The 17% is going to be greater than 17 millimeters, and that's usually consistent with patients with very severe disease, very severe ectasia, some transplant patients, and then again, those patients with severe ocular surface disease, you're going to look to go in larger, 17 to 20 to 22 millimeters. And then what's interesting to me is looking at that 15 millimeter, or less than 15 millimeter with 18%. So that's almost 20% of the respondents that said they fit scleral lenses less than 15 millimeters. And the criteria really, that would be a mini scleral lens. So sometimes you will have a patient that does have a small aperture or from lid abnormalities or some sort of conjunctival issue where you may want to fit a smaller scleral lens. So it was a really nice distribution, but most of us are in that 15 to 17 millimeter for our prescribing patterns for scleral lenses. Now in 2020, the second scope study was done, same cast of characters, but now we have a little bit more robust data. They went up to about 900 or so respondents, and it was definitely much more of an international flavor to this particular study. And what we're finding is that most respondents back in 2015 were more in academic practice. And then, scleral lenses again became more available to a lot of other practitioners. They felt more comfortable prescribing it. So this became a little bit more community-based rather than academic-based. And that sometimes will influence, your prescribing. If you're an academic center, typically you will see much more challenging eyes. Not always the case, but people like Suzanne, she's in a very specific academic setting, and she sees very, very challenging eyes, as you'll see during some of her cases in a little bit. But what was interesting as well is that when you look at the breakdown from 2015 to 2020, most of the patients, up to 80%, were fit for corneal irregularity. Only 10% was for ocular surface disease. So the idea is that, still the majority of our patients are being fit for corneal irregularity rather than ocular surface disease. So what are some of the therapeutic indications of scleral lenses? And this goes back, doing research back to even 1962, 70-something years ago, 60, 70 years ago, where Ridley had talked about using scleral lenses not only for, for vision correction, but also for therapeutic purposes. And we know that scleral lenses provide protection and lubrication as well as vision rehabilitation. A lot of Perry Rosenthal was really one of the forefathers of the sort of modern rebirth of scleral lenses. Even back in 2000, he had a paper in the American Journal of Ophthalmology talking about healing PEDs. So this was something that, even way back when, 20-something years ago, that was discussed as being possible therapeutic benefits of using scleral lenses for these type of patients. So we know that scleral lenses, the way they work is obviously to correct vision, but it's a fluid reservoir that increases contact time. And when you wear a scleral lens, it's really minimal and in a lot of cases, no tear loss, and that the reservoir basically continues to keep that fluid inside during wear. We know that when you look at typical traditional eye drop installation, there's dilution of the medication. It can cause toxicity, especially things like glaucoma medications. And when you do an eye drop, obviously there's different techniques, different size bottles, different size openings of the bottle. So patients will have different as far as what amount of drops actually get to the cornea, get to the eye, and how much of that actually is absorbed. So you can get dilution and again, the toxicity. And also dropper tip contamination. We're very aware now with some of the new reports and about these, these contaminated bottles. We don't want to use obviously a dropper that has touched either the eyelid or another substance. So you have to be very careful about using eye drops. And also compliance is very important when you're dealing with very, very complicated corneas, where you may have an issue where patients either forget to use the drops, they don't use them appropriately, their technique is wrong, they're dropping down the cheek. So these are things that we kind of look at and say, is there maybe a better way for us to actually treat these patients? And what we're going to talk about now, obviously, is using scleral lenses in that way. So when we use therapeutic scleral lenses, when you apply medication to them, and this is, again, a lot of us are not going to be doing this, but there are ways to actually utilize scleral lenses as a medication dosage device. So should we have the patient sleep with the lens versus have them wear it during the day and remove it at night? That's one question, and that has not been answered. Which medications can be used? And we'll talk about that in the next few slides. And should we use preservative-free? And obviously, and if at all possible, yes, let's do preservative-free, because this is a medication that's going to be trapped against the cornea all day long when they're wearing the scleral lens. So some of the other questions that we have are what is the potential dosage or concentration of the medications when you're putting it into the scleral lens bowl? As I said, it's retained in there the whole day. It's getting diluted by the saline. So how much is actually getting to the cornea? We know that it's trapped there, but how much of it actually is going to be diluted and get into the cornea? Can there be toxic reactions? Again, if you're not using the correct medication or using too strong a dosage, or potentially medication that has preservatives, can that cause possibly a toxic reaction? Some of the medications also just by themselves may cause a toxic reaction. And which filling saline is best? Really, the studies don't show which one is the best to use. We may have our preference as far as using bottled saline versus individual vials. So again, which is the filling saline is best? We just don't have all those answers. So one of the medications that we can use, and some that I've used in my practice, is moxifloxacin. So moxifloxacin is 0.05%. It's a 4th generation fluoroquinolone, and it's really self-preserved. There's no BAK. So that is hopefully going to minimize some of that toxic reaction that can have with certain medications. So this is really my go-to really for any patient that I do have using the scleral lens with an antibiotic. And to be honest with you, when I do in bandaged contact lenses for soft lenses for things like abrasions and erosions, I'll use moxifloxacin would be my #1 choice. It is available as a generic, so it's it's relatively inexpensive, pretty easy to get. All pharmacies have it. We even have we buy bottles to have in the office when we do insert lenses and such to enable us to do that within the office. Anytime you're doing one of these type of maneuvers with patients using drops of antibiotic or any medication in the lens bowl, you just have to obviously watch out for infection and wound healing as well. So this is just a study that came out last year, 2 years ago, in cornea, and it did talk about 12 eyes of patients. And all these studies that I'm going to show you really they're basically case studies. They're not actually full research papers, because again, these are things that are not used very commonly. And I wanted to just make you aware of some of the more recent research in this area. So this was one where patients had infectious keratitis. Most of them are culture positive bacteria, but there were a couple that were mycotic, a couple of them were not culture positive. So they used 12 eyes and they followed them for a month. They used moxifloxacin, as we talked about, 0.5% in the lens bowl for a 24-hour period. So the patient basically wore the lens for 24 hours. Then they took the lens out briefly, and then they cleaned the lens and replaced the lens with new saline and new moxifloxacin. So that one drop of moxifloxacin stayed in the eye for the 24 hours. And you can see in the conclusion that basically they did have pretty nice resolution in just about all the cases. Two of the patients were the mycotic infections that did not work with the antibiotic, of course. So this is possibly a way to treat some of our patients with infectious keratitis using a scleral contact lens. And this is also using a PROS device back in 2015. This is at Weill Cornell, talking about a PED, or persistent corneal epithelial defect, using moxifloxacin, again, 0.5% in a PROS scleral lens. So they, again, used the lens for 24 hours. They used it until reepithelialization was achieved. So this was, again, 8 eyes, so not a big number, but these, again, in this particular case, all 8 eyes basically resolved. So the conclusion was it continues to have a PROS device, constitute an effective state treatment option for refractive persistent epithelial defects. So there are other options other than moxifloxacin that you can use to fill a scleral lens ball. One of them is called autologous serums. You guys are probably familiar with this. This is when they spin down the patient's own blood and you constitute into a percentage and used as an eye drop. So I've had a few patients that I've done autologous serum drops in a scleral lens ball. You do obviously have to be concerned about sterility and infection, but if you have to, and you have to watch these patients very carefully. But autologous serum drops works very well. I've used it in patients with neurotrophic keratitis and non-healing PEDs as well. And the other one that you can consider using scleral lenses in, which we'll show in cases in just a moment, is anti-VEGF, like Avastin. And this study here used, again, a PROS device. A lot of you know Deborah Jacobs in Mass Eye and Ear in Boston. And this was 13 sequential patients treated for corneal neovascularization in Boston site between 2006 and 2017. So basically these patients were being treated for ocular surface disease and using as a daily wear lens for treatment of neovascularization. They used 1 drop, 1% preservative-free Avastin twice daily. So they took the lens out, refilled it, and put it back in. And patients continued with daily wear device, and they went through that whole process. And they did show that, again, in these 13 patients, that they basically did show they used patients with Stevens-Johnson, graft versus host, corneal transplants, and contact lens-related corneal ulcer and limbal stem cell. So they did follow these patients for up to 10 years. Median was 6 months, and 12 out of 13 patients actually had regression of the corneal neovascularization, and 10 of the 12 actually had improved best corrected visual acuity. So then there was no ophthalmic or systemic complications. So using Avastin in the lens ball may be effective in those patients that you're treating for corneal neovascularization. So consider that in those type of patients. And just looking at, what's the ramifications of the cornea when you're doing this type of maneuver. So this was another study, again, using the PROS scleral lens device. And it just showed that we had really no change to the endothelial cell density or morphology. Kristen had talked earlier about, looking at the endothelial cell count and also looking at the pleomorphism and polymagatism when you're analyzing your endothelial cell count and your specular microscopy. So this again shows that the relative safety of using these type of devices with patients with ocular conditions. So just some new futuristic things to discuss that I came across doing my research. One of them is using a scleral lens as a telescopic system for age-related macular degeneration. These patients will require spectacles over to kind of dial in what you want to do for the magnification, but that's another option that we do have for patients with macular degeneration. So not just using it for therapeutic on the cornea, but also using it for other things such as age-related macular degeneration. And then the other device that I wanted to go over with is the Mojo device, which some of you may have heard of. It's been reported in the late press as well. And we were at GSLS, I think, a couple of years ago, and there was a demo during GSLS. I think it was Jeff Sonsino who's the one that had the lens, and he wore it during the meeting, and he was demonstrating it. So this is a device that is almost like augmented reality. So it's almost like a pop-up, like some people have on their dashboard. So this is a great device, again, for partially sighted patients. It kind of can do a lot of different things. Unfortunately, there's been some changes to the company recently, and right now they're kind of changing their business model a little bit. So this has been put on the back burner. But this may be the way of the future, to allow scleral lenses to actually help us in other ways other than just for corneal disease. And this is kind of the sequence of where it was in development. All right, so just to finish up my part of the lecture, I just wanted to just briefly show you for further reading. There's a great group of papers that came out in the BCLA Journal, the Contact Lens and Anterior Eye, called the Clear Report. And the one I just wanted to reference here is the medical use of contact lenses and just the approach of what we can do to help our patients. And this is not just for scleral lenses, this is for all type of contact lenses. So this is a really good research for you to look at. And what I did come across when I was doing, preparing for this lecture, I found that really prior to this Clear Report, there was no accepted definition of the medical contact lens. But this Clear subcommittee on medical use of contact lenses did come up with this definition that I wanted to leave you with. It says medical contact lenses are any type of lens that is worn for the primary purpose of treating an underlying disease state or complicated refractive status. So other than our normal, keratoconus or post-surgical patients, there are a lot of different uses of scleral lenses, not just for vision correction, but also for treating, very severe, challenging ocular surface disease and cornea conditions. And this is what Dr. Sherman is going to be talking about momentarily. So really think outside the box. Thank you for your attention. And I'm going to pass it over to Suzanne now.
Thank you, Steve. First, before we get started, I want to thank you and the Scleral Education Society, Scleral Lens Education Society, for having us, and for Steve for lecturing with me. I hope you guys are all having a nicer day than we are in New York City, rainy and a little depressing, but a great day, as Steve said earlier, for a scleral lens soiree. So yeah, the first slide is think outside the box. Now that we've kind of gone over basic diagnoses of what scleral lenses are used for, and Steve kind of told you what's up on the horizon, I want to show you some cases and things that you might not have thought of, and maybe you have, and you just haven't really had the push to do it. And why? How can we grow our practices? How can we make our specialty, our niches, more represented in the medical community? And through these cases, I'm going to show you, I kind of created these patient cohorts of referrals from the patients themselves, but also from their providers that didn't exist before. So I'm going to walk you through how these were created and how I grew them, and how you could do something similar. Before we talk about those, we have to also go back to reality. And the reality is that all these cases that I'm going to present to you are great, but there were a tremendous amount of them that I'm not presenting to you right now that didn't work out so well. And why not? Well, for many reasons, right? Number one, sometimes the underlying disease or condition didn't work well with a scleral contact lens. Number two, I always say this to my patients, the benefits have to outweigh the risks of wearing the lens. And if I don't feel that we're getting enough benefit and there's a cost, then we're not going to do it. And then also, patients always have the right to say, this is not for me. I'm not going to do it, even if, deep down, I think it's going to be wonderful. And that happens. And I used to take that really personally, like I had failed. But I think, what I've learned is that, everybody's different. It's not for everyone. And how I approach these with patients is I tell them, this is a unique medical device that we have to make your life more functional. You don't have to wear it a certain amount of hours. You don't have to do this or use this. This is a tool we have in our toolbox to make you more functional, make your life easier. So let's figure out if it's something that can be a part of your life to make your life easier. So let's get into it. So this is never say never, because this patient was referred to me maybe 5 years ago. And some of you may have seen this case before because I have used it in other talks because it kind of was when a door really opened for me. This might have been in 2017 or 18, I don't recall. And it was referred to me by an oculoplastic surgeon who had never sent me any patients, and then sent me this one and said, can you help me with glasses and dry eye for this patient? And she came in and she was a young female in her 20s. She was a graphic designer in college. And this is what she looked like. She was 20 in her glasses, and she had really been through a lot. She had a systemic history of severe chronic progressive external ophthalmoplegia, CPEO. We all learned this in school, and I think the thing I took home from it is one of these patients whose eyes don't move. So when you're doing BIO and you're trying to get them, or slit lamp, and you want them to look a certain way, they can't. But what we also, we probably learned, and I just don't remember, is that they also can have severe dry eye. So she had tried a ton of things. She had tried Xiidra and Restasis and Cequa and ointments and plugs, all the things we normally kind of throw at this kind of problem. She had tried ptosis crutches, which actually made her dry eye worse. And more recently, she had been told by two of our oculoplastic surgeons who are very well known for these kind of cases that she was not a great surgical candidate. So I checked her glasses, I checked her dryness, and then sitting there, I said, you know what? I want to just try something. I said to her, bear with me. I want to try something. You're not going to walk out of this place with anything different. I won't leave anything on you. But if you're willing to let me try this, I just want to see if it gives us anything. So you see her there. This is something, she has secondary ptosis from CPEO, a mitochondrial disorder, for 17 years. She walks around with her chin up like this at all times. Her right eye, the lid falls 1.5 millimeters below her pupillary axis. I mean, can you imagine, right? Her right eye, her interpupillary fissure is I think 4.5 millimeters or 4 millimeters, and the left eye about 4 millimeters. So in office that day, I grabbed the largest diameter lens I could find and I put them on. And this is what we saw. She went from 4.5 millimeter and 4 millimeter interpupillary fissures to 6.5 in both eyes. So that's around, a 2.5, 3 millimeter improvement. Which, is it perfect? No, but is it a significant improvement in a patient that walks around with the top picture? Absolutely. So let's get into this. And I put the ruler there. This is obviously not to scale, but let's get into how we fit these patients and how this really works. So when I got this patient and I did this, I said, let me look at the literature and make sure I'm not doing anything too bizarre. And there were only about 4 or 5 cases. And honestly, most of them, I think all of them were unsuccessful for different reasons. And this is a grid put together by Chris Cherney, who is also an optometrist and a specialty lens fitter who was working with me at the time as a student. And what we found is our patient was uniquely successful for a couple of reasons. One, she's young. She was in her 20s. She still had the skin on the lids was tighter. The muscle was a little bit stronger. She was less progressed in her disease. And 2, she had never had any prior surgery. So a patient who's had prior ptosis repair may not get as great of results. That was unique to that individual patient. Now, in terms of fitting, why did we do what we do? And let me explain to you what I did. So when we think of scleral lenses, a lot of the times we think go big or go home in terms of lens if you have a really severe cone, right? So you need a larger lens to get over a higher apex. And, I think Steve mentioned before, similar to Chris, fit large lenses. We were looking at the scope study. Not one lens in this lecture is between 5 and 17 millimeters, to be honest with you. But I did start out fitting between 15 and 17. It's just evolved over time. So I say go big and go home. Why? Okay, this is a patient who has no ability to move her eyes in any direction. When we walk down the street, wind comes, dust comes. She doesn't have what you and me have, where we can quickly move our eyes to protect ourselves. So we want to protect the cornea, the entire con. So we're going big. Then she has extreme dry eye. So we want to give her a large fluid reservoir to help with the dryness. Also, we want to create a shelf from the top of the scleral lens to help with her ptosis. In order to do that, we have to push central clearance or sagittal height to its max. So her fitting, I ended up telling myself I could be at about 500 microns of central clearance, and I didn't think I needed to be worried. Now, this is different than a patient who's post-graft or a patient who has a compromised cornea for endothelial reasons, or some of those other cases that were discussed earlier. This is a healthy young patient, a healthy eye in terms of cornea health that we're fitting a lens in. So I went large in diameter for protection and for dryness, and I went large in sagittal height to give a bigger shelf for her eyelid to rest upon. One other thing I did try at the time, and my patients, I say this to them, I've learned from being burned many a times that I number one, like to fit in a very stepwise approach. I don't like to make more than one change at a time so that I know what change created what finding I get that day. So I first went large sag, big lens, and fit very loose. And then I tried to manipulate the optic zone in the superior quadrant to see if I could get even more of a lid lift. And what ultimately happened was it was not any more successful. So in my mind, I said, in the future, optic zone manipulation, superior quadrant, not worth it for me. I also decided in this patient that I was going to make it so she could wear her glasses without the lenses and still see, so that she didn't need a separate pair of glasses to wear with the lenses. And I decided going forward, I would basically do that with any of these patients because it's an additive layer of protection. And then I also combined the use of apnique with this patient and with the others. Some I get better results than others, but it is something that you have to add on. Don't do these all at the same time, right? You fit them in their scleral lens, you give them that 1 or 2 millimeters or 3 millimeters of improvement, and then maybe you'd add in the apnique, or vice versa. Maybe you try apnique first. I've done that with other patients, and then add in the scleral contact lens. So I'm going to show you a couple more patients. This one on the top is a patient of mine who's in her 70s. She has CPEO as well. She has never had surgery. Her anxiety that goes along with her disease process might cause more gray hairs for me than my own children, but I still went along with it, and she's wearing lenses. The patient below that, my colleague, Dr. Rebecca Rojas, who, when I've been out, has kind of taken over some of these patients for me, fit, and this is him and his lenses. So now, because of this first case, she went back and she told her entire community of CPEO patients about me and about this option that they didn't know they had. And honestly, right away, they came pouring in New York City. When I say pouring for, mitochondrial disorders, it's not actually so many, but I was seeing them regularly, 1 a week at least were coming in. And then they went back to their providers and said, did you know this was even an option for me? Why wasn't I referred in for this? So this is what I'm talking about in growing a cohort of patients that through their own community, they bring you referrals. This is another young gentleman who, he has CPEO. He's in his low 20s. Dr. Rojas is actually working on him, and he started with about 4 millimeters to 5 millimeters of intropalpebral fissure, and now has 6 in one eye and 8 in the other eye. One thing to keep in mind with these patients, and just to remember, is that with CPEO, they often have muscular EOM problems. So in his case, actually, by lifting the lid on the right side, we ended up getting double vision. He had always probably had the underlying double, but the lid was acting as a barrier or filter or deprivation, so he didn't notice the double vision. But by opening up the eye and lifting the lid, he started seeing double. And actually, right now, he's just wearing a lens in the left eye, and we are working on figuring out what the amount of prism we need to get fusion, if we can get it. And then we will actually refit him probably in a much more custom lens that can incorporate prism, and then a pair of glasses with the additive prism on top of it. So you see I have CPEO and then the ptosis. I don't mean, with CPEO you have ptosis. I mean, this is a cohort of patients that can range from the severity of having the condition of CPEO to just the average Joe that with age and time develops a ptosis. So I now have in my clinic a large amount of patients who come in or that are referred for a either congenital ptosis, an acquired ptosis, a post-trauma ptosis, that I fit them in a scleral lens for. Now, how do I use this as a practice builder for me? I often say to the patient, well, with ptosis, you have a couple options. You leave it alone. Okay, you have a ptosis. 2, you try something like Upneek. 3, we can try a scleral lens. What the scleral lens will do is will, number 1, help if you have any dryness, which a lot of these patients do. 2, it gives you the ability to go out in the real world, see what it would be like if your pupil was lifted, if your lid was lifted 2 or 3 millimeters, and see if it makes a significant impact in the quality of your life, right? And then you know whether it's worth it to have a surgery or not. Or, as I said in the very beginning, then you have a new tool in your pocket that you can use. A lot of the patients say, well, the ptosis doesn't bother me day to day, but when I go to a wedding or something like that, I notice in all the pictures, my eye doesn't look open. Well, there you go. When you go to these events, you can wear your scleral lens. It helps with your ptosis. So it becomes more of a cosmetic thing, but it still is aiding and the underlying thing that's causing your patient to feel less successful in their day-to-day and less confident. So we are making the patient more functional, which is really my goal at the end of the day. So I think my point is with this is that, there is such a range of patient with just getting an improvement in lid lift that you could use with a scleral contact lens, and having the confidence to go big or go home, and knowing that you can fit a much larger lens with a looser fit and not worry as much about central clearance. Pros lenses have really showed us that you can really be generous in a healthy cornea. So I'm now going to take a turn into another category of patients, or another cohort of patients I have developed over the last 5 or 6 years at Columbia. And again, I do have a unique practice because I'm at Columbia Medical Center and I'm in the heart of New York City. So I am getting referrals from a lot of people, and I also have direct access to all these doctors just through Epic. But cancer treatments, and when I talk about cancer treatment, you might think, oh, she's, talking about ocular oncology, but I'm not just talking about ocular oncology. I'm talking about ocular oncology. I am talking about treatments for systemic cancer. I'm talking about localized cancer treatments. These are all things that you might not realize will affect the front surface or ocular surface, but they do. So cancer treatment can affect the cornea by the way of, like a radiation keratopathy, which usually has a variation of manifestations. And it's not actually directly related to radio-treated patients having damage of the cornea, but it's really more the consequences of the severe dry eye that they're really dealing with. You can get limbal stem cell deficiency, meibomian gland damage, lacrimal gland damage, goblet cell damage. A lot of these patients have eyelid complications. You can get, again, meibomian gland damage, structural irregularities, ciliary body disease. And I took this picture, my colleague and a good friend, Dr. Julia Canestraro, is actually at Memorial Sloan Kettering, which is a major cancer institute in New York City. And she has just recently brought scleral lenses to their department for this exact reason, because all of these patients can really benefit from their use. So this patient here, the one with the large eye and the redness, is a patient that Dr. Canestraro actually referred to me years ago before she had lenses, who did not have cancer of the eye. She actually had adenoid carcinoma to the left side of her face and her neck, and she had radiation. Sadly, they actually attributed it all to being a volunteer at 9/11. And she came to me and was complaining that her vision wasn't as good. She wasn't even really coming for a scleral contact lens, but the more I examined her, I realized she had zero lacrimal gland production, tears. Her meibomian glands were completely shot. And she also had developed a protective ptosis. Patients that get severe corneal infections, patients with terrible dry eye, often develop a protective ptosis that slowly comes down. So in my mind, I thought, okay, we're going to go big. Why? Because we're going to cover the whole cornea from the nasal to the temporal end, because she has zero tear protection, right? Her actual cornea was in great shape other than being dry. Again, I'm not worried about hypoxia, endothelial function to that severe extent. When I say I'm not worried, it doesn't mean I'm not checking it or watching for those things. It just means that I'm not taking the school of thought that you have to fit with less than 100 microns. It's not a keratoconic patient where they might feel like they have better vision if I fit it as close as I can to the cone because they wore RGPs or things like that in the past. And you see that image, that's her with her lens on. Now she had tried every bandage contact lens possible. They all fell out. She was miserable. The eye was red. And she's now able to wear a very large diameter scleral contact lens comfortably every day. She feels that her her lid is higher. So she looks more symmetrical in photographs. And she's very happy. I think the most challenging thing for her is that she does not produce tears. So the front surface of her lens is not wetting well. And at the end of the day, you have to say to the patient, that is a limitation of the lens, but also of your underlying condition. It's never going to wet well. We can't, I haven't developed, and I'm sure someone in this group who's brilliant will, something that automatically replenishes tears at all times. But even with hydropeg and preservative-free tears, regularly, she still has some areas of non-wetting. To the side of that is a bunch of pictures of another patient who has radiation keratopathy due to having Merkel cell carcinoma on the side of her face. She had the radiation done. She thought she was better. She thought she was okay. And then all of these other sequelae in the eye started to happen. And she really didn't understand why. She didn't have any radiation to the eye. She didn't have cancer of the eye. Her lid doesn't look great, but that's not actually from the Merkel cell. She had a sty at the time. She has significant chalasis in all different quadrants, almost as though she had a bleb or something that filters all the way through. And she also is being fitted in a lens, in a very large diameter lens with significant clearance to help with covering everything, plus also lifting the eyelid and getting her the best achievable vision. This patient is one of my absolute favorites, and I think I'm seeing him next week actually. And I call him why because that's what he kept saying to me when we first met. He had squamous cell carcinoma of the maxillary sinus orbit skin of the left cheek, and after all of his surgical reconstruction, he was left with a lag of ophthalmos, but also radiation keratopathy. He had radiation to his face. And I first saw him about 5 years ago. He lives far away, maybe 5 or 6 hours away up in upstate New York. And he had seen a large number of doctors who had tried different lenses on him. And I think they just hadn't fit a patient like this before. And he came in to see our ocular oncologist who brought him up. And I did something similar. You'll see the theme of a lot of mine is that I fit him from that nasal canthus area all the way as far temporally as I could. Now, I do need to note that a lot of these patients, actually everyone I've presented to you so far, I fit them in a diagnostic trial lens from a trial set. I did not do any profiling. I did not do scleral profiling. I did not do impressions on these patients. These are patients where I had a trial set in my office, and in my opinion, a very good company trial set that I'm very comfortable with, that give me very large diameter options. And I was able to fit them in those. And that was important to me for a couple of reasons. Number one, cost. A lot of the patients could not afford to have used a higher end lens. Two, I was able to get these patients covered by their medical insurance, not all of them, but the majority of them, based off their underlying pathology and medical conditions. So I just want to remind you, this patient, we ended up fitting him in the lens, and why hadn't no one done this for me before? I've been living in agony for years. And what we did was we fit him in a large diameter lens with significant clearance and a loose fit, and I grew his wear time. And what eventually we did was he wore this lens from first thing in the morning till bedtime. He took it off for 1 hour, cleaned it, and he had a second lens he would put in right before bed, and he slept with that throughout the night. And Steve talked about the papers in which, there's a couple papers out there in which patients have done that. And that's what this patient has been doing since 2018. And he's monitored by us every 6 months now. And there is a local doc up there that knows him and knows me, and if he has a problem he can go to. But this is the kind of patient where wearing that lens basically 23 hours a day has made his quality of life dramatically better. Now, I left his glasses prescription alone. He wears them on top so that if he doesn't want to put in the lens for some reason, he has that ability. This is another patient that was sent to me. This is a young lady in her 30s with Gardner syndrome and biopsy-proven invasive squamous cell carcinoma. This patient, you see if you look closely at the corneal picture, has, Salzman's nodules, neovascularization. She had some thinning of her cornea, chronic dry eye, obviously exposure, keratopathy, and she really doesn't have a lower lid. So in her case, her eye is open to infection. She's had multiple herpetic attacks in that eye. And she also gets some severe trichiasis. And those of you who have seen patients who have had lid surgery specifically for these kind of things, the trichiasis that comes back is not our average hair. It's a thick, jagged hair. So fitting her an extremely large diameter lens to give her the ability to make it through the day without discomfort was necessary. And in this case, we had to use a much more custom lens. And what did that lens do for her? If you look at the picture to the side of her whole face, you see she had developed an extreme protective ptosis. So that lens opened the upper eyelid. It created a shelf almost, a lower lid, almost prosthetic for her, so that she didn't have this constant pooling and tearing of tears on the lower lid. And she was having to cover that with Tobradex or Vaseline all the time. And it reduced that for her. And her as well, we ended up having to do something where she slept with it, a separate lens that she cleaned at nighttime, and she wore this during the day. These patients may come off as extremely severe disease, and they are, and I'm not discrediting that, but I think that these are the kind of patients where if you manage them and co-manage them with a team of people, and your patient is aware and you have said to them, if this goes any step in the wrong direction, we're going to pull it, and the lens is not going to happen anymore, and you stay on top of them, then these lenses can make a significant improvement for them. Unfortunately, this patient was very young and had severe disease and did not get to wear this lens for a long period of time. But while she did, it was a real deal breaker. It was a real breaker for her in that it made her day-to-day so much better. Here are just a couple other examples. A patient of mine who had conj melanoma, status pulse, multiple excisions and biopsies in her eye, and she had cryotherapy. And here the lens is used for similar things as we talked about, right? For exposure, but also for protection from an irregular lower lid that had trichiasis, but also to lift her upper lid for her ptosis. And she wore that lens every single day until she passed from the disease, and it made her life better. The one next to that is a patient of mine who had a brain tumor resection and ended up having to have some radiation to the face. And she ended up not having any ability to use her lid. And you see she has developed some scarring and things, and cosmesis is something she's very self-confident. She has a lot of confidence issues about, and in her case, just being able to again open up the eye and make it more similar to the other eye, and then also keep a new ledge. You can't tell in that picture, but she didn't really have a lower lid that was normal, and this lens created this crevice. So this is again is a very large diameter lens, fit loosely because we're not really fitting it necessarily for vision, we're fitting it for comfort, but also the cosmesis aspect of it. This one is different than the rest of those you just saw in that the eye and the aperture is much smaller, right? So when I saw this patient, she had basal cell carcinoma, and the cornea was exposed at all times. And I think it's hard for you to see, but the upper lid, there's two areas. You can see she has jagged trichiasis. They're like little daggers. And she was having to come in once or twice a week just to have those removed. And you can also see that upper lid is buffed up, it's beefy, and it's coming down and it doesn't really have any movement. So in her case, we actually had to do more of an impression molding to get it to fit. She also has an area of scarring nasally, and we fit from the nasal quadrant to the temporal quadrant to open up her eye, but to protect her all day long. And she's also protected all night long. These patients, I always do a trial run during the day, right? I always do the lens wear test. And I do these in my graft patients as well. How many hours can you wear it? And I keep pushing it and pushing it and pushing it. until I'm confident that they could make it through the night wearing a lens also. And then at that point, I asked them to order a second lens. And then we trade off between the two. One is being cleaned while the other one is being worn. This is a very recent patient for me. This is now he's 10 years old, but around, I think 4 years ago, he had a medulloblastoma of the cerebellum, which left this little boy wheelchair bound, and not just an average wheelchair, a severe wheelchair. He's not able to hold his head or anything. And when I met him, his entire eye on the right side was sutured closed, the entire eye completely sutured closed. He had had a tarsorrhaphy for 3 years, and the parents decided, let's open this eye up. And what I found challenging was, how am I going to fit a lens on the eye if I haven't seen it? But the oculoplastic surgeons wanted a lens immediately for when the eye was opened up. So we fit based off the other eye, and then we got him in a lens. In the beginning, he was red and was pretty angry, but honestly, with time, it did very well. And the point of the picture here is to show you that, again, he didn't have tear production. So you see where the lid showed, it was nice and smooth, but there's non-wetting on the area where the lid doesn't wipe. So preservative-free tears and things have to be used. Here's some other examples of PED that the patient has to sleep in the lens. Really quickly, just to remember, stability is a category that scleral lenses can be used for. Patients with Marfan's, nystagmus, this is also another area that I've grown my practice. These patients have to get quick areas of sharp vision, and having a stable lens that doesn't move around is very helpful for them. So I want to go back to what Steve said before about the most commonly fit conditions. We know of these, and these are all very important conditions to be fit in scleral lenses, but these are not the only uses for scleral lenses. And I think it's up to all of us to, grow this and add to this, and just within our patients and our case reports and lecturing and discussing like this. Before we finish, I just want to thank Wu Yu, the Scleral Lens Education Society, Dr. Sorkin, and my colleagues, Dr. Canestraro and Dr. Rebecca Rojas.